This is where the complete strategic planning project comes to a close. Part 1 started off with the internal and external analysis of Mayo Clinic's Department of Medicine and thus determined its position in the market. Part 2 saw the formation of the strategic plan based on the above analysis. Part 3 saw us create the implementation plan. The purpose of this submission is to explain what has been changed. So here we are. Before moving into strategy, a common understanding needs to be reached first. Mayo Clinic's Department of Medicine is no ordinary hospital department because it is an integrated, non-profit, physician-led group practice organization for healthcare provision, research and teaching. This alone is a strategic strength because the resources allocated to each function strengthen the other. The department already has over 900,000 telemedicine visits yearly, making it digitally equipped. In terms of competition, it competes in the national market for complicated referral services, where it competes with other organizations for patients, talent, and research grants. 3 emerging trends are changing this market according to the Strategic Management Framework by Rothermel. The internal analysis recognizes the assets that can be developed through strategic planning. 4 of them have been selected. First, the system of digital patient care is already running on a large scale rather than being a pilot project, thus reducing the risks of its expansion. Secondly, leading national rankings of specialties still bring the department high volumes of referrals, talented physicians, and money for research. Thirdly, the integrated model of practice itself represents the capability of the department as shared governance in patient care, research and education facilities, the implementation of the strategic plan. And finally, a strong research and innovation capacity enable the department to implement new care models and AI technology in a thorough manner. In order to conduct the external analysis, Porter's 5 forces is used. The competition rivalry has increased due to competition among the academic medical centers for digital access and performance results. The barrier to entry has reduced with the entry of new rivals such as telehealth services that are available for the general public. The buyer's bargaining power has increased due to expectations from patients and referring doctors regarding hybrid scheduling as a norm. The presence of substitute service providers such as retail clinics affects the patient visits for lower acuity visits. The supplier power exists in the form of AI and technology platform providers, as well as a shortage of specialists for scaling. Instead of taking a direction, we get one from our analysis. The TOES matrix puts our strengths and weaknesses that have been analyzed along with the opportunities and threats that we face externally, which will lead to strategic choices that we can connect to the evidence in the process. In the first quadrant, with strength and opportunities, we can leverage the current digital capabilities and reputation to scale our hybrid specialty care services. In the second quadrant of strengths and opportunities, we need to solve any digital literacy problems to make sure that the increased demands for telehealth do not increase inequality. In the third quadrant of strength and threats, our reputation can be leveraged to differentiate us from other players with low-touch services. Following the results of the TOES analysis, the preferred strategy would be to pursue disciplined hybrid specialty growth via related diversification of delivery channels. Now, what does that mean? It means that the scope of the effort would be limited to developing hybrid or in-person virtual delivery channels in selected specialties of chronic disease management and post-discharge care, and not an all-inclusive initiatives. It would be related to diversification according to Rothermel's corporate strategy model, expansion of an existing business capability into adjacent offerings, and not a leap into completely different industry, therefore carrying significantly less risk. The scope is also limited in terms of time frame to 12 months from now. First, Mayo has provided more than 900,000 virtual visits, which makes clear that this is not something experimental, hence reducing the risks of implementation. Secondly, there is now a market pull. because patients and referring physicians are increasingly expecting hybrid scheduling. More importantly, the 2025 study by Wamala, Anderson, and Gonzalez suggests that digital health literacy is the key determination in determining which people will benefit from digital transformation. In other words, the lack of safeguards during scaling will deepen disparities in access. Finally, Hubner and Falasa's 2022 study on systems thinking makes it evident that healthcare strategies should take into account long horizons of time and uncertainty, which is precisely why our plan discussed below is phased rather than immediate. 4 strategies put the strategic direction into action. Hybrid care pathways include structured use of both virtual and face-to-face patient care, specifically for managing chronic disease patients and post-discharge follow-up care in certain specialties. The use of AI for coordination involves using AI technology for triage assistance and coordination, but clearly not autonomously, and with a focus on clinicians' oversight of the process. Workforce redesign ensures that the hybrid care pathway does not increase the workload of clinicians but helps reduce it. Global partnerships are established only after a thorough risk and fit assessment according to the Rothamels framework for global corporate strategy. This roadmap answers the feedback asking for more specific implementation timelines. We use a staged 3-phase approach over 1 year, following Ali's 2025 evidence-based staged implementation framework. In the first 90 days, we prioritize 2 to 3 specialty service lines, define a governance charter and equity indicators, and establish baseline data on wait times and workload. In days 91 through 180, we pilot the hybrid pathways, complete staff training before any technology scaling, and test digital literacy support services. In days 181 through 365, we scale only pathways meeting defined readiness thresholds and publish the first performance dashboard results. This staged approach is what reduces risk before any system-wide expansion. Because this strategy touches clinical AI, patient data, workforce change, and potentially international partnerships, governance cannot be an afterthought. 4 oversight bodies manage it. The AI Oversight Committee reviews any AI tool for safety, fairness, and clinical utility before deployment. The Data Governance Board ensures transparent, accountable use of patient data across virtual and in-person touchpoints. The Equity and Access Council monitors digital literacy barriers as hybrid pathways scale. Mayo Clinic 2025. The Global Partnership Review Panel assesses regulatory, financial, and cultural fit before any international agreement. Mayo's own financial reporting shows global partnerships can be complex. Together, this structure lets Mayo grow without outgrowing its ability to maintain its own quality systems. Ali 2025. Now, this dashboard uses specific metrics and measurable indicators, making use of 4 domains in response to the feedback provided on the need for performance indicators that are measurable. In terms of access, our targets include a 15% reduction in the specialty wait time and 85% virtual follow-ups completed. In the quality domain, we aim for no increase in 30-day readmissions and patient experience scores that should not be less than the baseline. As far as the equity domain is concerned, inspired by the research by Wamala, Anderson, and Gonzalez 2025, our target includes provision of digital literacy to at least 90% of the enrolled patients. Mayo Clinic's Department of Medicine can increase specialty care access without reducing trust within the institution. The solution is evidence-based, since the application of the TOES approach ties the analysis we conducted to the strategic decision made rather than prescribing a course of action. It is feasible building upon an existing digital capability rather than introducing unrelated new capabilities. It is regulated by 4 oversight mechanisms, controlling AI risks, data risk, equity, and partnering risk from day one. It is measurable via real-time performance dashboard rather than a one-off claim. And it is a system-based, echoing Huebner and Flessa's idea that the strategy of healthcare should be based on uncertainty. Scaling up will have to rely on evidence from this dashboard. Thank you so much, and I look forward to your questions.